Morning or good afternoon. I'm sorry not to be able to travel and be face to face so that we can share on this topic on Mpox in children and pregnant women. I'm going to share some lessons learned from the Democratic Republic of the Congo. Just a quick recap to remind that the first case of Mpox was identified in 1970 in the DRC. We have clade 1 that circulates mainly in Central Africa, and clade 2 that circulates mainly in West Africa, and that was responsible for the global outbreak. We have on this graph the cases in the past 12 months in some African countries, where you can see the red color representing DRC that it has a lot of cases, but we have also high numbers of cases in Uganda and Nigeria. At a certain time, we had many cases in Burundi as well, but there now the situation seems to be under control. And here we have the epidemiological trend in DRC. We can see there were some period of interruption in the transmission, and cases appearing in other countries, Ivory Coast, Gabon, South Sudan, Nigeria, and so on. On the right side, we have a map showing the DRC. Red color indicates the provinces where we have clade 1A circulating, blue color provinces where we have essentially 1B, and the purple color showing the provinces where we have both clades, like it is the case for Kinshasa, the capital city. The confirmed cases, you will notice the number are very low compared to suspect cases. This is just because of the low testing capacity, but presently efforts are being made to improve, to increase the testing capacity. Labs are being set up across the country so that the gap hopefully will be reduced in terms of confirmation. This gap is shown on these graphs. We see on the left one showing the suspect cases, and the other one shows the confirmed cases. So we know that many cases, as I just said, are not, many patients do not have the chance to get tested. So the diagnosis sometimes ends at the clinical basis. So some challenges we are facing in the country. The first one is having both clades, 1A and 1B, circulating at the same time. But we also see, which is not really a challenge, it could be taken as a good sign. We see a decreasing trend in confirmed Mpox cases. However, we need to be careful, as it is not 100% clear if this decrease means the disease is being controlled, because the decreasing number can hide maybe a weakened surveillance system, or the reporting system that may be affected by the reduced funding supporting the health system in the country. We note sometimes delays in shipping samples to the laboratories, and also the turnaround results. Sometimes patients wait for several weeks before they get feedback from the lab, or sometimes the results are not sent back at all. We have also a slow implementation in community engagement, which needs really quite a lot of investment of stakeholders and the community towards the engagement of everybody in terms of Mpox surveillance. How about pregnant women, which is the focus of this talk? We know that pregnant women are at risk not only for themselves, but also because of the vertical transmission of Mpox in fetus. There is a publication that has recently reported 4 cases of vertical transmission, among which only one fetus survived, most probably because the mother had a mild disease. But in general, we see miscarriage up to 62%, vertical transmission around 80%, and maternal Mpox is linked to fetal loss in nearly half of cases. Now coming to the pediatric population, although during the outbreak, the global outbreak, the number of children was quite limited, in DRC, we note that many cases, the case fatality rate is high in children, and that is mainly due to clade 1 that is circulating in several provinces, but also both clade 1A and 1B have an impact on young age children in terms of disease severity, of course, mortality and complications for children who have the chance to survive. And the children in DRC have a higher risk of Mpox compared to those from non-endemic countries, where we have mainly cases due to or propagated by travelers because of close physical contact to wild animals that could be reservoirs. In many villages, children go for hunting small rodents, and they can get infected. But we know that with, in particular with clade 1B, the transmission is sustained by human-to-human contact. We also see poor sanitation, weak healthcare system, and low vaccine coverage, which may indicate or be responsible for the vulnerability of young children. On the right side, we have these key elements that highlight the factors of pediatric Mpox transmission in a contextualized socio-economical model. These figures from the Ministry of Health indicate that children below 15 years old constitute the largest population of cases that have been admitted to Mpox treatment centers, which means we need really to focus onto this age group in order to better control the disease. The common symptoms are skin lesions and in fever, lymphadenopathy. In severe cases, we have encephalitis, sepsis, and secondary infections as well. And some cases, we can have complications like blindness, as we can see on the photo in the middle. Some children can become blind, and that can be irreversible. The risk factors for severe disease and death are malnutrition, which is quite high in the country, HIV infection, and of course, lack of vaccine access. In this observational study that was published by Emile Malembi and collaborators, we saw that higher Mpox severity and mortality in endemic provinces is noted among children, which highlight the high burden and complication in this age group, which is also a call for action that is should be focused to this particular population. We note some gaps in treatment and vaccination. We know that there are challenges in access to treatment and even access to vaccination. In particular, there are no vaccine at the moment approved for pregnant women and children of a certain age. Recently, in DRC, the indication of the MVA-BN vaccine has been uh, lowered by age, starting at the age of 1 year, which is already good to give a chance to those children to get protected. But now there is a high urgent need for coordinated approach to protect both children and pregnant women. So these two groups must be prioritized in the research and action. So in the plan to advance pediatric and maternal Mpox research, the Department of Tropical Medicine at the University of Kinshasa is involved in several research studies. Among others, we are conducting the Pregin-Pox-Vac, which is a phase 3 trial testing the safety and immunogenicity of MVA-BN vaccine in pregnant women. In this case, we compare the vaccine to postpartum women. So pregnant women are randomized. A group is vaccinated during pregnancy, and another one will be vaccinated after delivery, and we will compare which is when is the best time to administer the vaccine. We are also enrolling infants aged from 4 to 24 months. We are also part of the VEDI project, which is an observational study conducted in several countries on Mpox in children and adolescents. It allows to make an epidemiological analysis and also to document the clinical presentation of cases in these particular groups, so that we are contributing to a combined data set that will allow having a broad overview on the disease presentation in children and adolescents. We are also conducting the POX MVA 045 trial in Kinshasa on safety and immunogenicity in children aged 2 to less than 12 years to adult for whom this vaccine was indicated long time ago. So we believe that more is needed in terms of focusing on children and pregnant women in terms of research and data generation. So to end this presentation, I think children and pregnant women are among the most vulnerable to Mpox endemic settings, as we have seen during this presentation. Clade 1B can be vertically transmitted across all trimesters of pregnancy, which means we need to protect the mothers and protect the fetuses at the same time. We need urgently to include pregnant women in Mpox prevention and surveillance and vaccination strategies. And for that, we need first to generate data to make sure that these interventions are safe for pregnant women and young children who are vulnerable, but most of the time excluded from several clinical trials. Now comes the time to thank you for your attention.